Good morning, everyone. This is Stephanie Orzekowitz, IPMG's Professional Development Specialist. Thank you so much for joining us for our May informational webinar session, Hoarding, Understanding, and Treating the Chaos. Before we get started with our presentation, there are just a few items and reminders that I'd like to go over. Today's webinar recording and all associated materials will be available on IPMG's website within 2 to 3 business days. You can find this information by visiting the resource section of our website. You can also find information for past webinars as well as register for upcoming webinars in this location. All attendees will be provided with a survey at the end of this presentation. If everyone could please take a few moments to complete this survey, it would be greatly appreciated. We do use your feedback when planning and preparing for future informational webinar sessions. And lastly, all attendees will receive a follow-up email within 2 business days containing a certificate of attendance as well as the link to the survey. And now I would like to introduce our guest speaker, who is a returning guest for us. Leslie Shapiro is a licensed marriage and family therapist in Washington State. She completed her master's degree in couples and family therapy at Antioch University in Seattle. Prior to obtaining her master's degree, she worked as a residential organizer and coach. She has previously served as a member of the King Pierce County Hoarding Task Force in Washington State, and she has been the lead educator and staff consultant at THP Consulting. Leslie also facilitates support groups for individuals who hoard, as well as for friends and family members of people who hoard. We're so excited to have Leslie back with us today. So without further ado, I am going to hand over the controls to Leslie. Leslie, the floor is now yours.
Awesome. Thanks so much, Stephanie. I'm so happy to be back. So let's get started. Okay.
All right, we can see your screen.
You can, awesome, okay. So the first thing that I like to go over about hoarding disorder is there's a lot of myths out there that can be quite damaging to family members and folks that struggle with hoarding. And I'm sure some of you, or a lot of you, have seen the shows Hoarders or Hoarders Buried Alive, and it actually makes my blood pressure go up because of the way they treat hoarding. So some of these are, I think, some of the myths that come out. So she's just lazy. He refuses to clean. Those people won't change. Just take it one room at a time and it'll be no problem at all. You're not even trying. I'll clean the house while he or she is gone and give them a fresh start. Those people are pigs, disgusting, crazy, sick, and there's nothing wrong with them. They just need to knock it off. So the challenge with these and the consequences is that it can really damage relationships between individuals that hoard, their family members that have a family member that struggles with hoarding, and neighbors and communities. It can create a lot of anger, disgust, humiliation, shame, guilt, hurt, and frustration to the people that hoard and also the family members as well, as a lack of trust happens because it damages the relationship. And this has potential re-traumatization of people who hoard. I would say that it is very traumatizing for them to be labeled like anyone else struggling with other mental health conditions. This sounds negative, but it's a waste of money, time, and human resources. And this is referring to doing forced cleanouts. And then what happens with those forced cleanouts, and that means where somebody goes from having a full house down to the bare minimum, they end up going back to hoarding, and it gets twice as bad. So the first thing I'd like to talk about is what is hoarding disorder and what it looks like. Before I talk about that, hopefully most of you are familiar with the DSM5, and if not, that's no big deal. It's the Diagnostic Statistical Manual, number 5, and we kind of call it the Bible of mental health diagnoses. So social workers use it, counselors, therapists, psychologists, etc., when they're looking to diagnose to help treat. And in 2013, the DSM-5 came out, and hoarding disorder was its own diagnosis. So that was really exciting because before that, it was under obsessive compulsive disorder. And they, in fact, learned that it was a separate disorder from hoarding. So these are the 4 criteria that we look for someone to meet in hoarding disorders. So the first one is excessive acquisition of stuff. Hopefully you can see that asterisk because not everybody that hoards struggles with excessive acquisition. And what that means is constantly bringing stuff in the home. So dumpster diving, if they see something, you know, somebody leaves like a dresser at the side of the curb, they can't stop, they can't help but pick it up. They know all the sales, they know the sale days. So in here in Washington, it's called Value Village. I don't know if you have that, so Goodwill. So they know the days if there's the special sales. And they're just bringing in items. Now that's not universal in everyone that hoards. So some folks, you'll think they're bringing more stuff in, but it's because they struggle with the other criteria that I'm going to talk about. So the second is difficulty discarding with possessions, which probably sounds obvious, but it's not just a difficulty, it's emotionally and physically draining to them because it causes them so much distress to let go of things. So they have a really, really hard time. Their living spaces can't be used for the intended purpose because of clutter. So I'm going to use the word clutter a little bit, and I think sometimes it gets confusing between hoarding or a hoard and clutter. But what this is talking about is somebody almost has to kind of shimmy their way in through the front door, and they have what we call is goat paths. And so they're not able to just walk in. The other things that we look for is they might not be able to take a shower in their shower because it's filled with items. The bathroom is so full of items or clutter that they can't, you know, brush their teeth or use it, or even sometimes access a bathroom. I've had clients in the past where one of their bathrooms was completely full. They might be sleeping on a recliner chair instead of a bed because they can't get to their bedroom anymore. Or if they are going to their bedroom, they're crawling over stuff sometimes or climbing on stuff. And then the other one we look at is the kitchen and living room, but in particular the kitchen. A lot of times the clients that I work with that have hoarding can't actually cook in their kitchen because the oven's covered, it's used for storage. The refrigerator might be broken or have spoiled food in it, or both because it's broken. And they're just not able to use their kitchen for its intended purpose. So that's what that's referring to. And this is talking about causing significant distress or impairment. So where that causes distress is occupationally, financially, and just personally in their life. So occupationally, they might not be able to, and I'm generalizing, but they might not be able to keep a job because they're late or they're super disorganized, so they can't find their second shoe. And it just shows up in their workspace because that too gets cluttered, sometimes, not always. The other way is financially, they'll spend all of their money on items or storage units or things like that, so it affects them, or they can't find the bills to pay them, or they can't even access your computer to get on there to pay for items. And then socially, it really, really affects the folks around them. That doesn't just mean family, it's the whole, if you think about it like an onion, it affects them if they have grandchildren or if they have friends or anybody that wants to be socially engaged with them. It's tricky because they typically don't let people over. I've had clients in the past where they've spent money on taking everybody out for breakfast because they had book club and they never wanted them to see their house. It can cause rifts in families because they don't understand hoarding disorder, or they've tried to help and it doesn't get better, and they feel like the people that struggle with hoarding care more about their stuff. And so that little asterisk says not universal in all people who hoard. And again, that's excessively acquiring, bringing in items constantly. So how many people hoard, and are they more likely to hoard than others? So this percentage is rated between 2 and 6%, but I actually think it's lower because there's so much stigma and shame associated with hoarding that people don't self-report or don't report it, or they don't let anyone in so nobody knows. So if you think about it differently, it's 1 in 20 people struggle with hoarding or know somebody that has hoarding behaviors or has a family member that struggles with hoarding. So I think Stephanie said there's 400 people here. I hope that's the case because I'm so happy to be here training this. 1 in 20. So I don't ask me to do the math because that's not my strong point, but just if you were able to look around the room, it's a lot. They used to say the age of onset was between 9 and 15, but they've done a lot more research recently, and they're noticing that the age of onset is actually right around adolescence, so between 11 and 15 years old. And it's a lifelong disorder. There's a misconception that people with lower income hoard less than people with higher income, and that's just not true. I think we see it more because they don't have the means to hire people or the means to get the help they need. So be that, you know, with a professional organizer or a therapist or, you know, anything like that. And people with higher income are able to hire people and they're able to buy bigger houses. When I was an organizer before I went back to school, I had actually somebody that really struggled with hoarding disorder, and they just bought a bigger house. And gender differences, that's another question that comes up. Depending on the research article you read, some say that it's more men and some say it's more women. And then there's also different traits, which are kind of stereotyped, but women tend to excessively acquire via shopping, where men acquire, but it's in different cases. It's not necessarily shopping, but that's not always true, of course. So there's a lot of different causes of hoarding, but because I was trained in family therapy, and I think it's important to look at it that whole way because it takes a village to treat hoarding disorder, we look at the biopsychosocial model, and all that means is that there's a biological aspect, there's a psychological, which is probably obvious, and then social. So biological is there can be a family history of hoarding behaviors or hoarding disorder that gets carried down. I know it's the nature versus nurture, right? So are they learning the behaviors or are they innately there due to a genetic chromosome? It's a steady course and progression throughout life. So I mentioned that it starts at 11 to 15. And there's brain functioning differences, which I'll talk a little bit about. And then the psychological aspect is there's co-occurring diagnosis. So what does that mean? That means that somebody with hoarding disorder can have ADHD or anxiety or depression or OCD. So typically there's not one mental health diagnosis of a hoarding disorder, there's typically more. There's a lot of unresolved trauma and loss. In the last couple of years, there's been a lot of phenomenal articles that have come out on trauma and hoarding. And the trauma that we refer to is not just like a typical loss, like the death of a loved one or the death of a sibling, but it can be any kind of trauma. So it can be what we call chronically being invalidated as a child. So everything you do is wrong. Basically, your emotions are wrong, the way you act is wrong, and things like that. The cognitive distortions are referring to the way people think about their stuff that they hoard, because there's a skewed perspective on the way they think. And then there's behavioral reinforcement. If I could see everybody in the crowd right now, I'd ask how many people avoid doing things they don't like. Well, I would guess that 90% of you would raise your hand, because hoarding feels good, and getting rid of stuff doesn't. So of course they're going to want to reinforce that behavior because that's the thing that feels good. That's their coping mechanism. Social major life transitions or events. So that can be a family that, you know, is doing well financially, is, you know, middle income, and then somebody loses a job or something, and then their income goes down, or like I said, somebody passes away from the family. So it's a major event or life transition, or they move around a lot. It's more about moving around a lot and less about just having a different home. So it's a lot of times I'll talk to people that were their family was in the army and they're constantly moving, and then they're forced to let go of things, and that can really cause a traumatic response depending on who it is. And then I mentioned this before, but hoarding is a really big burden on families. That's why we have that support group, because sometimes people that live in the home feel like they don't have a space in the home because their spouse or partner is taking up the whole house, and they feel inundated with their stuff. She's just going over it more. So I talked about the biological, and I don't think I mentioned information processing deficits, and I'll get into that in a little bit. The psychological, so I talked about the co-occurring diagnosis. And the one thing I didn't talk about is the stigma and shame associated with this, is there's a lot of stigma and shame because of those shows. Now they were good because they brought hoarding awareness out into the open. The bad is that those myths, I think, are associated with that. So there's stigma and shame from the folks that hoard, and then also their family and loved ones. The other thing I don't know if people think about a lot is that hoarding is the most visible mental health condition because it's all out there for everybody to see, versus depression. You can hide pretty well. Same with anxiety. Same with OCD, with the exception of maybe washing your hands to ensure that they're raw. So this is something I think is really, really important to go over, which is the difference between clutter, collecting, and hoarding. So Stephanie mentioned that I used to be a professional organizer. This is not a picture of my house, but I have kids. They're now teens. I have twins. And I can tell you that on any given day, my house might look like this because it's cluttered. But here's the difference. The people that live in this house would be able to readily let go of things. So if, the parent said, hey kids, we're gonna have a garage sale, or, and we'll give you the money to, help with the garage sale or whatever, there wouldn't be distress associated with letting go of things. In this house, believe it or not, it'd be fast to pick things up, say you're gonna have somebody over. It's not impairing them socially, occupationally, or financially. So you see that person, it's kind of hard to see, they're working on the couch. So they're able still to move around and able to use their home for intended purpose. This is one of my favorite pictures of collecting, because I actually have a friend that didn't have quite this many, but he had kids and then sold all the action figures. But this is an example of collecting. So the collection, again, they're able to let things go. They're able to sell things. They're not emotionally attached as much. It doesn't impede living areas in the home, and they're able to carry on normal activities. And again, there's not distress discarding. Now they might be like, oh, I'll miss that train set, but they don't get emotionally dysregulated over it. And this is hoarding. So possessions become disorganized piles of clutter. So everything's just kind of everywhere. They can't use their home for intended purposes. And it says here the motivation to display items is lost. And what that's referring to is there's so much they can't access it. So sometimes I'll hear from clients, if I just got that box that has the shelving unit and I put it out, I could, put my display out. Well, there's these intent to do things, but they don't follow through, partially because it's so overwhelming with all the stuff, and they just have a hard time getting to that point, but it doesn't mean they can't. So are there other mental health diagnoses related to hoarding? Absolutely. So Frost is one of my favorite researchers. He's been doing research on hoarding since the 90s. And he says 75%, that's like based on his research. You'll see his little citation there. I will tell you, I've been working with people that hoard since 2012, and I've never worked with somebody that doesn't have a co-occurring diagnosis. So they're not struggling with depression, anxiety, generalized anxiety disorder, personality disorder, ADHD. So that's what this is referring to. So again, the 75% is from Frost, excuse me, and then in the DSM-5, I think it says 92%, but I don't quote me on that. So I just wanted to kind of go over hoarding in older adults briefly, because I think it's important to address. So their symptoms of severity worsen every decade. This is just some research that's done. I mentioned to Stephanie that there's not as much research into nursing homes and community dwelling as I'd like, but a lot of them displayed hoarding tendencies once they moved into the home. And they definitely had them before they moved, and they will definitely carry that on to the next home when they downsize. Part of what I did as an organizer is I would do moves and help people go from a giant house into assisted living. And I saw that a lot, where they would have a really hard time letting go of things if they struggle with hoarding disorder. And it's even hard if you don't, to live in a house for 20 years and have to let things go. There's increased dysfunction in several domains of executive functioning. I'll talk about that in a little bit, but I always think of right here, I always want to put helmets on everybody when I think about the brain and how precious it is. So there's, they struggle with working memory, set shifting, etc. But I will get into that. And then there's major consequences for older adults. So there's an increased risk of falls because, as I mentioned, the goat paths, and because they're not able to let things go. It's also, it's harder to clean as you get older. I have parents that are in their 80s and 90s, and you slow down a little bit. Now, my parents luckily are still pretty active, but it's not as easy to do stuff. Sometimes it's not, you don't see what's at your feet. There's a higher risk of fire, food contamination, medication mismanagement, which what's that referring to is they either can't find their pills or they forgot that they took them because they don't have them organized. And then there's social isolation, which does happen as we age. Our partner or spouse might pass away. this is kind of depressing, I'm sorry, but as you get older, you start losing your siblings if you have them, and your friends start to pass away. So and then if there's the family implication where they have given up on that family member due to hoarding, that's another social isolation. And like I mentioned before, they typically don't let people into their home. There's also increased risks of medical conditions. So because they're not able to cook in their kitchen, they might be eating a lot of fast food or out of a microwave. They might not be sleeping in a bed. Like I mentioned, they might be sleeping in an armchair. There's a higher risk for hypertension, so high blood pressure due to eating not great foods. And then, asthma and allergies, sleep apnea, all of that comes into play. Challenges with hoarding in older adults is there's age-related problems. So there's a reduced capacity to cook, clean, bathe, and sleep when they're struggling with hoarding disorder. And like I mentioned before, there's a decreased amount of physical and emotional supports as people age, which is really sad. The other things that we sometimes see is organic brain illness like dementia or schizoaffective disorders, or TBIs or traumatic brain injuries. So what that's referring to is sometimes somebody will not have hoarding disorder or display it at all, but as they age, they might have the onset of dementia or a traumatic brain injury or a stroke, and then they start hoarding. So I've seen that. And then due to that, they have a hard time developing insight and changing behaviors, unfortunately, when that happens, because it's not actually hoarding disorder, it's dementia. In these cases, harm reduction models would be most beneficial, which I'll be talking about later. So I think it's really important to check in and talk about the brain, because their brains just operate differently. So we'll hear things like, don't they see how filthy their house is? Don't they care? And it's such a simple decision. Why are they getting so upset? So there's two main questions that I just want to go over. Why don't people who hoard seem to notice the clutter or get upset in daily life? And why do seemingly simple decisions seem so difficult or have no ability to make these decisions? So there's brain functioning differences in folks that hoard. So their frontal cortex, which is decision-making, executive function, process of reward value. And what that means is they get that dopamine rush, is not always the best. And they have a failure to get upset, and they not always have great insight. So I'm just going to go over the Salience network really fast because I think it's really important. So folks that struggle with hoarding disorder, their Salient network doesn't work like other people. So what the Salience network is, it's folks that don't struggle with hoarding disorder, they are able to make decisions rapidly like that, and they're doing it so automatically they don't even know they're doing it. People with hoarding disorder don't have that rapid decision making. So if you think of it like this, for people that have a Salience network that without hoarding disorder, it's their brain, it turns on and off. So it's like on, off when they're making decisions like the mail. So if I got the mail out of my mailbox and I was sorting it, my Salience network is going like that really fast and I don't even know I'm doing it. People with hoarding disorder, it's constantly on. And instead of using the automatic Salience network, they're using their frontal cortex. And so they have to think really, really hard about decisions. So it's more painstaking, it's more thought out, and it's slower. So does inability to make decisions run in families? Yes. So again, it's the nature and nurture. So there's actually a chromosomal link that they found in hoarding. And then I also think it's a learned behavior for a coping mechanism. So it can be both or one or the other. This says it's also been linked to inattentive ADHD. There's now articles out that are saying, oh my gosh, it's right. Hoarding disorder does have similarities to ADHD, which we've known for a really long time, but now there's like actual research on it. So when I'm talking about executive planning, this is what I'm talking about. Activating the brain so that you can organize and sort and prioritize. You're able to sustain focus and keep on track. So instead of churning with, which is what people that hoard do, they'll have something on their desk and they can't decide where to put it, so they set it down. And so it's a bill. Well, I need to pay this, but I don't know where my bank account number is, so they set it down. Well, this is a picture that somebody sent me and I don't really want it anymore, but I feel bad getting rid of it. So they keep kind of churning, or they move things around to try to make it better. And as they're moving things around, they lose their attention. So for example, they find a screwdriver in their kitchen that they were using. And they're like, well, this needs to go back in my toolbox. They go to their toolbox and they get completely distracted by the tools. They struggle with emotional regulation. So just keeping calm and steady while doing that. They really, really worry about not remembering things. So folks that hoard try to keep everything for fear that they're going to not remember, which is the complete opposite. People with hoarding disorder have ridiculously good memories. And then just taking action is really hard. So purposeful planning is another one that they struggle with. So the over and under categorization is they either make, so if you think of a file system, and say you were doing you're sorting your 2022 taxes, right? So they either make one file that has everything in it for taxes, or they have too many, they have so many categorizations that they can't find stuff. So again, it's either oversimplified or it's way over the top and they lose track. The other reason that you see lots of piles when you go into someone's home and they don't have excessive acquisition is because they really rely on their visual memory so that things are out so they can see them, because if it's out of sight, it's out of mind. There's a lot of excessive, exaggerated feelings and ideas about possessions, which I think are really important. There's beliefs, and then there's attachment. So there's a sense of responsibility. So throwing this out as a wasted opportunity, or it's my responsibility to take in all the people that don't recycle or throw food waste away properly, and they feel like it's their sole responsibility. Or I'm going to keep this for my friend, and when I see them next, I'm going to give that to them. Or I might need it someday as another one. There's a sense of control because they didn't feel like they had control as a child or as they got older. So when somebody talks to them about letting go of something, they kind of stick their talons into that object. There's a sense of waste. So they really believe nothing should be wasted. And if I save it, I'm not wasting it. So these are some of the beliefs. And the attachment is some people actually anthropomorphize with their objects. So what that means is they become a person to them, like a friend. So if they let go of that item, it's like letting go of a friend. So that could be a doll, that could be, stamp collections, what have you. And possessions of memory, just throwing something away or letting it go is like throwing a memory away. So those are some of the beliefs and attachments they have. So how are these showing up in hoarding disorder? So everybody thinks this way about possessions, right? So some people are like that with photographs, some people are like that with tools, but the thing that's different with hoarding disorder is that they think this way more often. They think about it more strongly, so that when I'm talking about those attachments and those beliefs, it extends to a broader range of possessions. And they have a difficult time being flexible, so they have rigid brain, they have a hard time changing that flexibility, and they feel like they almost need to obey their thoughts and feelings. And I think that's where OCD or obsessive compulsive disorder got confused with hoarding disorder, because there's obsessiveness about getting that next thing because there's a dopamine rush related to it, and that's what that's talking about. So the two main questions are, why don't people who hoard seem to notice the clutter or get upset about it in daily life? They have an underactive salience network. So there's so much stuff that their salience network that I mentioned before is just on instead of making those fast decisions. And the brain isn't signaling that something's important. It's not likely now, they say, to be simply talking about it with habituation. So what that means is somebody's so used to the hoard around them, they don't see it anymore. Now that does happen, but there's more going on. So the habituation part is talking about just being so used to something that you don't see it anymore. So why do people that hoard have a hard time making decisions? Their brain is signaling that everything is important. Their frontal lobe, which is right here, has a complicated reward processing. So their reward for doing something doesn't activate the way our brains do. There's cognitive deficits, especially with attention. There's indecisiveness. There's emotional attachment to items. There's maladaptive beliefs about possessions. And it's easier to avoid making tough decisions. Well, I think we all do that, but it's specifically hard for folks that are trying to get rid of stuff that hoard. The maladaptive beliefs about possessions are, I'll give you a very quick example. It's a Frost video. He has an actress come in, but she's pretending to be somebody that struggles with hoarding, and he has her bring one item in, and he's doing the downward arrow cognitive behavioral therapy technique. So it's where you ask a question about something that has an erroneous belief or a maladaptive belief. So for example, he said, I'm going to have you look at this red sweater that you brought in today, and I'm not going to have you get rid of it, but I want you to talk to me about why you're keeping it. And she says, well, it reminds me when I was still married and Christmas, and my sister bought it for me, and I think she's going to get mad at me if I get rid of it. But on the other hand, he says, well, what's your relationship with your sister since you hoard? And she's like, well, we don't talk. She thinks I'm disgusting. So on the one hand, she's hanging onto the sweater because she's worried her sister is going to get mad at her. But on the other hand, her sister is not even talking to her. So that's what that's talking about the maladaptive or cognition deficits. So safety and reporting. I'm sure a lot of you know a lot about this because you're mandated reporters, but I like to go over it. There's a lot of safety and health risk with hoarding. So I mentioned before, there's fire hazard blockages. There's blocked exits, so means of getting out. There's a lack of routine home maintenance because, you know, the person that comes in to maybe clean their filter out or help them with their water heater can't get in the house. They can't clean as properly because there's so much stuff. There's actually can cause structural damage to places, in particular with housing. And then there's legal problems. There's a risk of eviction, homelessness, and applications for services. So they have a hard time using the wonderful people in the audience that are caseworkers because they're too scared to have people come in. There's an impaired functioning with health, so poor hygiene and grooming and nutrition, because as I mentioned, they might not be able to use their bathroom for intended purposes. There's kitchen. There's an inattention to medical needs, just again, for fear about going to the doctor and being caught. There's inadequate financial management, which I talked about. So there's compulsive buying and losing unpaid bills. And then there's a difficulty cleaning around clutter because they can't get to it. And they sleep on their floor instead of their bed. And then the other thing that comes up is due to that. So in the Pacific Northwest, we struggle more with mold, which I'm from the Midwest, so I know there's not a lot of mold in Indiana, as bad as Seattle. But you know, there might be a more increased risk to mold, dust, which increases allergies, asthma, headaches. And then there can be insect infestation or rodent infestation due to the home not being properly taken care of, which can lead to hantavirus or cat scratch disease. So so people ask, if I can't clean out a home or do a forced clean out when it's hoarded, what am I supposed to do? What if there's no time to do therapy? So the quick answer, and you're going to hear me say this a lot, you're probably going to be dreaming me saying safety tonight and being like, Leslie, stop saying safety, but safety always comes first. So safety means, you know, can they get out of the home? Or if God forbid an EMT came in, can they get them out? Are they able to, or do they have spoiled food? Are they able to find their medication? The next thing that happens is skills. So what is skills? That's emotional regulation, that's making decisions, that's staying on task, that's purposeful planning. So it all comes into play with the frontal cortex. And then organization. So sorting, categorizing, and getting rid of stuff. Then therapy will follow. And this is, when I'm talking about this is if somebody has like bed bugs or there's a fire in their home or something like that. And then you can approach grief, loss, and trauma, and then hoarding, which is excessive acquisition or not getting rid of anything. So at what point is it reportable? If you're a mandated reporter, and if somebody's an endangerment to the health and safety of a child or minor, somebody that's older than 60, and then somebody, or if somebody in the home struggles with a disability, and that includes intellectual disabilities, not just physical. Self-endangerment can also be considered reportable, so self-harm, like harm to self. So again, what we look at, so this is talking about building codes from county to county, so they differ everywhere you go. But when you look at health, they can't use your bathtub, shower. I've already talked about that. The obstacles, you know, are things going to fall on top of them? Are they going to trip and fall? Is it going to block heating vents so it starts a fire? And then structural damage is, you know, when it gets really bad, caving in walls, stuff is too heavy, there's too many electrical cords, there's no running water. So screening is another one that I think is really, really important. So I'm going to show you a lot of assessments, and I am happy to email them all to you. So I'll go into talking with somebody that struggles with hoarding a little bit later, but some of this you'll see again. So you need to ask. So it can be really uncomfortable to ask people about their home if some of you in the audience are mental health workers, but it's essential, because how do you know if you don't ask? That'd be like not assessing for depression, anxiety, etc. So some questions that we ask are there any of your areas of your home that are difficult to access due to clutter? Or do you have a difficulty letting go of possessions? Do you know, excessively acquire? Does donating things become really upsetting to you? Do you have a strong urge to buy things you don't need? Another one that can kind of come up, which I've seen with folks that I've worked with hoarding developmental disabilities, is stealing, because they have that impulse control struggle sometimes, and they get so excited about like all the business cards at the doctor's office and they grab all of them, or the library where they have all those paper flyers, they'll grab all of them. And then the other question to ask is, have you ever been in an argument with someone due to the clutter in your home? That's a really good screening question. So I like to show the DSM5 page for hoarding disorder, because the top one that I think is so important is persistent difficulty discarding or parting with possessions regardless of their actual value. So something that could look like trash to you is a treasure to them. So the example I was giving Stephanie yesterday is I had a client who would collect shiny paper because he was a photographer. But if somebody saw that in his apartment, they would have been like, this is junk, this is a piece of shiny paper. But to them, it's a treasure. There's a hoarding assessment tool, which is one of the screens I like. And the reason I like this is it's not just for mental health workers. You can use it as a very casual interview. So you can do it in their home if you're going into homes, or you can do it, you know, telehealth if you're doing telehealth or televisits. It better understands the causes of the problems, features that might affect intervention, and avenues and impediments to change. So what's stopping them from changing? This is just more details into the hoarding assessment tool. It talks about the onset and duration of hoarding, the home environment and contents, their feelings towards objects, reasons for saving, reasons for organization, and things like that. The clutter image scale I really like. This is particularly good for somebody that doesn't have like a clean hoard, so they're not like a super neat person that hoards, which means they have, you know, neat stacks, everything, but the problem still is they have a hard time letting go of things. But it also talks about the room, not the person. So you show this image of the bedroom, and it goes from 1, which is a very sterile like hospital room, to 9 where you can't even like see the room anymore. And they have one for the bedroom, the bathroom, the living room, and the kitchen. The homes is another one that I like because it focuses on health, obstacles, mental health, endangerment, structure, and safety. So that goes over, again, all the things I talked about, like health-wise with hoarding disorder, and then obstacles or tripping hazards, etc. Mental health is not diagnosing mental health. It's actually just looking out for things that are off. So are they getting overly exaggerated with anger or irritability, or they're confused, or they're defensive? And then endangerment goes into folks that are that it's reportable. Structure and safety is talking about, you know, again, too much stuff, you know, walls being damaged, like where they're almost sagging from the weight of stuff and due to poor care of the home. The uniform inspection list is one of my favorite tools. My friend and colleague Marnie Matthews developed it. And the reason I like this is you can use it, it's for housing, but you can use it in a regular house or apartment as well. It really breaks down into smaller steps what you need to focus on. So somebody that struggles with executive functioning can't make multi-step directions. They need things broken down. So if you tell somebody with hoarding disorder, I need you to clean your apartment up or your house up or this room up by next week, that's so overwhelming to them. They don't even know how to do that or start. So it's breaking it down into smaller steps. The other ones that we have are the hoarding rating scale, the saving inventory, and which is a self-report measure. So that's good for a couple of reasons. One, it shows that they have any insight into their hoarding and how they see it versus others. So if they don't have insight, that's a good thing to be aware of too. And by insight, I mean, are they aware that they struggle with hoarding or think it's a problem? The ADLH, I'm sure you've seen, it's the activities of daily living, but it's with hoarding. In one of the studies that was done, there was 80% impairment in movement, 70% they were unable to access their sofas, 50% couldn't prepare food, 45% could not use their refrigerators, 42% couldn't use their kitchen sinks, and it goes on. So it really helps assess that, and I particularly like it for folks that are on have dementia or on the spectrum of intellectual disabilities, because again, you can ask the questions in a specific way. This is another favorite because it's rainbow colored and it's beautiful, and it's referring to the different levels of severity in the home, 1 being not bad at all, 5 being the most severe, so red. So it looks at the structure, it looks at animals and pests, household functions, health and safety, and protective equipment. So what does that mean? So that means are roofs caving in? Are their walls starting to be like, leaning in because of the weight? Are the floors damaged? Is there, are there animals and pests? So like an over excess amount of bugs or spiders that are beyond, typical spiders that come. Is there an infestation of rodents? What kind of protective equipment do I need? And then is the household functioning? So it goes from, again, 1 to 5, and it talks about the house, not the person. So if somebody calls me and says, Leslie, I'm working with a client that's a level 3, that's struggling with hoarding, I know what that means. So these are some examples. I just think it's good to have the visuals. This is level 1. This is not a problem at all. Level 2 is where you starting to see like the clutter on the countertops and on the right side of the screen, you see stuff starting to pile up. This isn't even that bad, believe it or not. This is when it starts to get elevated, and you need to bring in folks like Stephanie, who's a social worker, therapist, community network of people that can help with fixing things and stuff like that. So you start to need more and more people to help, because as you see, the floor is starting to close in where there's barely anywhere to walk, and things could fall on them. It's really scary. And this is level 4, which is where you have to like climb over everything. And again, you're wanting to think about like protective equipment, structure, pests, things like that. Level 5 is the most severe. So I was talking about like walls caving in and the roof caving in. This is what that's talking about. So you open the door and you can't even like get into the house. And this requires a whole team of people. So guidelines, I just wanted to go over this really quickly because I do telehealth, and I'm not sure if anyone else does this, but just for like if you're online with somebody, you can use the Clutter Image Rating Scale, which is that one. And then you can use the ICD, which is the rainbow one, determining the level of severity. And then you can ask the client or patient to show you their room with their video camera if that's available. And you can kind of look into all of those avenues using any of the screens I had for you that I showed you. And then just be observant and look around and see what you see. So hoarding developmental disabilities and dementia, I think is really important to address. So I worked with DDA for a while, going into homes and doing assessments for folks that struggle with hoarding and had developmental disabilities as adults. So they're going to need a lot of support from family and friends or service providers to maintain a healthy home. There's going to need to be frequent checks for safety, the removal of clutter, and then making sure to go back to that activities of daily living hoarding sheet to see that things are happening regularly. So are they able to use their stove if they have one? Are they able to use the refrigerator if they have one? Or can they get to their bed? Are they tripping over things if they just have one room? Things like that. And this is where I would highly recommend the harm reduction model for folks that are on the spectrum of developmental disabilities or folks that struggle with dementia and hoarding, because it's not about changing the hoarding behaviors, it's just minimizing the consequences of those negative behaviors. And again, the focus is on safety. So this is I like this slide because it talks about assessing for mental and physical capacity of somebody. So do they know what day it is? Do they know how old they are? Like, what is their mental capacity? And that includes just, assessing for developmental disabilities. Do they have positive and trusting relationships, which is super important for the person that you're working with that struggles with hoarding? That rapport is key and the trust is key. And then just working with appropriate agencies and minimizing safety hazards. So the high capacity, high risk is where they have the capacity to make decisions, but they have also a high risk of safety. So it's that when they have that, high of insight, we just need to accept their determination to get help. So they can either say, nope, I don't want any help, or they can. When you go into high risk and low capacity, that's when we start thinking about folks that have dementia or developmental disabilities. Sometimes, depending on what's going on, they might need to have a guardian ad litem or conservatorships. And when they have high risk, which is again risk of safety, and moderate capacity, that's actually the ideal, because they have the capacity to reduce risk and increase mental capacity and awareness. So what that looks like is they're able to recognize that they have a high level of safety risks, and they also have pretty good capacity to make those decisions. So I like this slide because it talks about the psychological impact of forced cleanouts. So this chart shows you somebody that's been hoarding for over 10 years, and then somebody comes and does a forced cleanout. So what that looks like is, like this shows, they come in and they empty everything out and they start with a clean slate. So what happens is the person is so traumatized that struggles with hoarding from the forced cleanout that they'll fill their house up that took them 10 years to fill up within 6 months. So that's how traumatizing it is. So unfortunately, sometimes it's necessary to do cleanouts, not forced cleanouts, but what we call a safety day. So if the home is hoarded and you don't have time to do therapy, what do? So here I say again, safety comes first. Ideally, it's always great to do the underlying issues. Speaking as a therapist, we can't always do that. So again, that's thinking about bed bugs, etc. So rules of thumb are safety first, skills second, and then everything else that follows that I talked about later. So the harm reduction model is similar to this clean needle approach, where you're not stopping the behavior, but you're minimizing the consequences. So for hoarding, that is to minimize, if you can, excessive acquisition, but not always, but more so harm reduction. So do they have spoiled foods? Are there tripping hazards? Kind of like all the things I talked about again. You always should include the person that you're working with that struggles with hoarding with us, because you want them to have that sense of fulfillment and have a say in what can go. So it also reduces the potential risk to neighbors. So that could be in an assisted living facility, that could be in an apartment, that could be in homes. So I get a lot of emails from condo owners or people that have neighbors that struggle with hoarding, or people that live in facilities. It can affect the neighboring walls. So it doesn't decrease the hoarding behaviors, but again, it minimizes the consequences like safety, hurting family relationships, stuff like that. And also people that aren't willing to seek treatment for hoarding. So harm reduction, again, is not stopping acquiring or cleaning everything out to reduce harm. It's a problem of hoarding that's unique. It's an interaction that's unique between the person, the condition, and their environment. So you need to create a plan. So I've done a lot of those harm reduction plans, like when I went into the adults that struggle with developmental disabilities. And then again, it's just keeping things safe, having them make different decisions that are going to affect them safety-wise. So again, harm reduction is safety first, then health and comfort. And this was hard for me to consider as a therapist, because I would think of comfort first, but the safety is the most important, because again, you don't want them to feel unsafe. Then you focus on health, which would be the kitchen, being able to wash their clothes, etc. And then comfort. So getting them in a bed, making sure they have adequate heating and stuff like that. So talking about hoarding disorder with clients is really important. So you need to start by asking those screening questions that I talked about before. You know, do you have difficulties in certain rooms that you can't access, or is there some rooms that you're not able to use adequately due to hoarding? Do you find throwing away things upsetting? Have you ever been in an argument with someone that you love? And then use the assessments that I provided, and we'll be happy to email to anyone. Remember that when you're talking with somebody that hoarding, that you don't need to beat around the bush. You can be direct, I mean, diplomatically, but you don't want to dance around the issue. That's why I like that uniform inspection list, because you can say, here's my safety concerns and here's why I'm worried about you. So it's talking about the safety and not their stuff. And then these are potential other parties that are involved. Housing authority, APS, CPS, hazardous waste sometimes gets involved, and then code enforcement. So when you're talking about that, you want to talk about how it's affecting the individual, the home, and then other people. And again, I'm going to say you want to increase safety. You want to reduce the risk of others to get involved. And what that's talking about is having a forced clean out. And what will motivate change? So here's an example of what they're saying. So I'll give you a different example. I had a client that was living in housing, and they were getting down to the deadline with their assessment. That's not the right word, but they were getting their home checked out, and it was like 2 days from now. And I said, you know, you're going to end up losing your housing and being evicted. And at first they're like, I'm fine with living in my car. And then it clicked for them, and they're like, okay, my motivation is not to live in my car. You want to be clear and quantifiable. Again, that's why I love that uniform inspection list. So here's the things that you need to do to make your home safe, ... And you want to make sure to keep the resources open. Again, sometimes you do need to report, but if I ever report on a client, I always talk to them about it first. I never blindside them with calling CPA or Adult Protective Services. So treatment and support. So what does it look like? Here's that safety word again. And then you want to really have an integrated approach for co-occurring disorders. So what does that mean? If somebody's struggling with substance use disorder and hoarding, you're going to want to treat this substance use disorder first. Or if they're struggling with crippling depression, where they're so depressed they can't get out of bed, they don't have the energy to shower, they're isolating, you're going to want to treat the depression first. So it's a combination of things that we do for treatment. There's cognitive behavioral therapy. There's motivational interviewing, what motivates them to change. There's organization training, decision-making training, exposure to non-acquiring. So that's having them actually look at something in a store and not get it, and sitting with that uncomfortableness. That's what the exposures we're referring to. And then coping strategies, because we want them to have different coping strategies instead of hoarding. So what can you do that's going to make you have that dopamine rush and that feel good that's not hoarding? There's more and more medications that are coming out for hoarding, which is exciting. So Pact or paroxetine, they found was not helpful. Effexor appeared helpful. And these are just SSRIs or SRNIs, which are reuptake inhibitors that help folks that struggle with a lower production of serotonin, etc. They've also seen some good success with folks that with hoarding take ADHD or ADD medication. That's been really helpful. And then, believe it or not, they've seen some Alzheimer's medications help. So motivational interviewing, I'm just going to go over really quick because this is a whole other topic. But the way I look at it is you don't want to work harder than the client. And I find myself doing that sometimes because I want it so bad for someone that struggles with hoarding. And I'll feel myself leaning in, which I know sounds silly, but your shoulders will feel tight. You'll feel stressed when you're thinking about the client because you're working harder than they are. So you want the client to figure out what their motivation is. One, it gives them a sense of autonomy. And two, it makes them feel really good about themselves. And they're likely to do those motivations to change because it's their motivation. So the way I think about it is that cheesy poster, I'm dating myself, that you saw with the footsteps into the sand. You want to be walking side by side with the client, not going ahead of them and not going behind them, but working with them collaboratively. So the emotional psychological impact of hoarding cleanouts I mentioned before, but I just wanted to show this quote. So this person said in all 3 instances in going and cleaning these places up, within weeks of relocating the individual brought back in stuff. So they reacquired, they like basically had a relapse of hoarding behaviors because it was like this forced clean out, and then they filled the home. And a lot of people just don't realize how traumatizing that is. But again, sometimes it's necessary when safety is a real issue. So when working with people that struggle with hoarding, you want to go slower. You want to make suggestions versus imposing strategies. You want to ask questions that facilitate thinking about what makes the most sense. So what does that look like? So that is talking about just thinking of, so an example would be, you know, if God forbid there was a fire and you had to grab 5 things out of your house, what would you grab? It's kind of changing that thinking and starting that thinking process. You want to encourage reliance on strengths, so verbal over visual memory. So really reinforce that even though they think they have a bad memory, you show them evidence that they don't, so that they're not encouraged to keep everything out on the surface. And then just be really compassionate and empathetic in the face of heightened anxiety and distress before, during, and after sorting sessions if you do that. Because again, remember, it's a mental health condition, and sorting and letting go of things is so distressful. So tips for hoarding work, again, there's assessment. So you always want to screen everybody. The more you do it, the easier it gets. And I guarantee you the person is less anxious than you are about asking about it. Because your anxiety about asking about someone's home, I have a feeling, is really high. So you just need to ask. You want to identify all significant factors, including, like I mentioned earlier, co-occurring diagnoses. And again, here's the safety. You want to think about safety first, skill building second, and deeper processing third, which means therapy. And you really want to try to work collaboratively. This says as resources allow, but it takes a village to treat hoarding disorder. You cannot take it on yourself. You need to have a support system. So I always like to almost end with solutions and hope. So resilience and the ability to withstand diversity, difficulty, and traumatic events. People are really resilient, and they can get better. And the resiliency really comes from having a support structure. So that could be, you know, family of choice, or that can be family, depending on what's going on with the family and the hoarding. That can be therapy, that can be caseworkers, therapists, excuse me, that can be social workers. So it's just having that feeling, not feeling alone, like they're in it by themselves. And that's why I really believe in support groups for folks that struggle with hoarding, because that sense of familiarness between each other, camaraderie, is really important. So there's less stigma. And then just building positive interpersonal relationships, again, is really important. And then having a supportive network for yourself, the person that's working with someone that hoards, but also the person that hoards. So some online resources are us. So we used to be the Hoarding Project. We became a for-profit, so it's THP Consulting. I am happy to answer any questions you have on email. Sometimes I'm slow to reply, but I always will reply, because I think it's so important to treat this the right way. The OCD Foundation for years would have a coming soon hoarding page, and now they have an awesome hoarding resources page where you can find therapists that work with people that hoard, but you really want to make sure that's a specialty and not just something they're clicking off in a box. So sometimes sometimes therapists will, you know, say they treat everything, and that's just not possible, in my opinion. The Mental Health Association of San Francisco is awesome. When I was just a youngish grad student, I reached out to Saxena in California, and he emailed me within 5 minutes because I was asking questions about hoarding. He does studies there. And then there's Tompkins, who I mentioned, who developed the harm reduction system. He is awesome. The Institute of Challenging Disorganization is where I got that rainbow chart, and they actually teach classes on hoarding. And then the Children of Hoarders, not my favorite name, is also a really great resource page. It's less, the page is not as great as it used to be, but it's still pretty darn good. And then reading resources, all of these books are phenomenal. I'll tell you, if you want to have an even better understanding of hoarding, is to read Stuff, because it really puts forward case samples and how they treated it. Buried in Treasures is an awesome book that people can either lead for peer-led, so people that hoard can lead it, or folks like yourself can teach it. And what it does is it teaches those skills, and the people that hoard work in a group together. And it's really cool. My very good friend and colleague ran the group and had high success, but the clients that are in it have to have the willingness to change and insight into hoarding first. The Treatment for Hoarding Disorder workbook is also really awesome because there's worksheets, assessments, etc. But I will tell you, my favorite person that does hoarding work is Tompkins, my favorite. And I'm kind of a hoarding geek, so I've read his books multiple times. But if you want to read about working with somebody with hoarding disorder and loved ones, Digging Out is the best book. So that is it. I've been keeping on time. Am I good on time?
Hi, yes.
Okay.
Thank you so much for presenting this information today. I know it will be invaluable as we continue supporting the individuals and families within our communities. So thank you again, Leslie. I really appreciate you being here and presenting today. Thank you for everyone attending. We are actually at our time limit, so we do not have time for question and answer. However, for everyone that entered a question, the Q&A document, as well as the recording and slide deck, will be posted on our website under the resource section. So be sure to check there in a couple of days and look for your questions to be answered. Again, Leslie, thank you so much. We appreciate you, and thank you everyone for attending, and have a happy Friday. I have a lot of thank you. Yes, I have a lot of thank yous to you, Leslie, and many comments saying how wonderful this presentation was. So thank you again.
Thank you. My pleasure. And I'll look for the email so I can answer the questions.
Okay, fabulous.
Okay.
All right. Thank you, everyone. Have a good weekend.
Bye-bye.
Bye-bye.